The Jerry Pal podcast is brought to you by Archstone Foundation, improving the health and well-being of older Californians and their caregivers.
Welcome to the Jerry Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do you have with us today?
Today we are delighted to welcome Anna Parks, who is a aging research fellow and a hematology fellow and is soon to be an assistant professor at the University of Utah. Welcome to the Jerry Pal podcast, Anna.
Thank you. Thanks for having me.
We're also delighted to welcome another aging research fellow and geriatrician, Matthew Groudin, who is at UCSF currently. Welcome to the Jerry Pal podcast, Matthew.
It's great to be here.
And we're delighted to welcome back Mike Steinman, who is an aducanumab lover.
Give me a bad rep there.
Tongue-in-cheek said that. I should say that, but not true. He's professor of medicine at UCSF, co-PI of the U.S. De-Prescribing Research Network. Welcome back to the Jerry Pal podcast, Mike.
Thanks, Alex and Eric.
So this is kind of a Polypharmacy De-Prescribing super special. We're going to be talking about a couple papers that are linked to that subject. But before we do, who has a song request for Alex?
I guess I can speak for myself and Anna. We picked this week Joni Mitchell's Case of You. And this is a favorite song of both of ours. And we also, we felt like if you really stretched your mind, you could come up with some analogy to taking a lot of meds. But we really just want to see...
From your case of medications.
Yeah. But we really just want to see Alex sing a perennial favorite.
Yeah. And it's the 50th anniversary of the Blue Album, Joni Mitchell's Blue Album. So appropriate. I won't sound anything like Joni Mitchell, but here we go. Just before our love got lost, you said, I am as constant as the northern star. And I said, constantly in the darkness, where's that at? I'll be at the bar, on the back of a cartoon coaster, in the blue TV screen light. I drew a map of Canada, oh Canada, with your face sketched on it twice. Oh, you're in my blood like holy wine. You taste so bitter and so sweet. Oh, I could drink a case of you, darling, and I'd still be on my feet. I'd still be on my feet.
Excellent. Thank you, Alex. So we usually start off these episodes on how you all got interested in this as a subject. We already had Mike Steinman on, so I'm gonna first turn it over to Anna. And we're gonna be talking about two JAGS papers that just came out. One on what Matthew did on polypharmacy among older adults, and Anna did one on long-term functional outcomes in older adults with AFib. I know you're a hematology fellow too. How did you get interested in this, especially for older adults?
Sure. Yeah. So honestly, it came from clinical experiences. And I think many listeners to the podcast have probably experienced this, where you have a patient in your practice who has a very good reason to be on blood thinners, meaning they've had a lot of problems with clotting. But you also have seen the downstream effects and the way that it maybe uniquely affects older adults. So they have a lot of bleeding. They call a lot about, nosebleeds, and maybe they feel afraid to lift up their grandkids because they're worried about bleeding. And I felt like those experiences and voices are just not well represented in the hematology world and in clinical trials. And so I got interested in trying to better understand those experiences and then use those insights to improve the way that we manage that fine balance between clotting and bleeding. So atrial fibrillation is sort of a model condition in that way, but there's a lot of them within hematology. So that is my story.
Yeah, this is a big clinical issue, right? Anna or Mike, maybe offhand, Like, there are a huge number of older adults who are eligible for anticoagulation by guidelines who just don't take the medication. So they're voting with their feet. And what we consider to be like nuisance bleeding to them may be a lot more than nuisance in terms of the impact on their lives.
Yeah, exactly. It's over 50% of patients who, for AFib, for example, by quote unquote guidelines, which are really based heavily on chronologic age, which we know is an issue, should be taking anticoagulation, but they don't. And I think we can gain a lot of insight both from clinical practice and also talking to patients and trying to better understand their experience. And then through papers like Matthew's and hopefully mine as well.
Well, let's do that. So I'm going to turn it over to Matthew. Matthew, how did you get interested in this? And then we'll talk about Matthew's paper. And then we'll talk about kind of Anna's paper and just thinking about particularly maybe we can dive into this anticoagulation topic because I know Anna also had a JAMA IM editorial on it. So lots to cover. Matthew, how did you get interested in this? Polypharmacy.
Yeah, I think similarly to Anna, for me, a lot was born out of clinical experience and in particular in training as a geriatrician, but also in internal medicine residency and in my early years working as a geriatrician. I've just been struck by some of the toughest cases I've seen are patients who are taking innumerable meds, often in the kind of 10 to 20 range. And some people talk about finding the area that makes you angry. And I feel like this is something that I get worked up about, where I feel like there are many cases that we come along where the kind of the amount of good that we were doing with our meds may not actually exceed the amount of harm that might be caused in some cases. And it can be very challenging, but I think also really meaningful to patients and intellectually stimulating to work through that with them and figure out where things can be cut back or kind of rationally de-prescribed. And we can talk more about that. And then I think, just from a policy standpoint, and I know a lot has happened in the geriatrics world with the recent approval of aducanumab, but I think a lot about the cost to society for medicines and kind of to Medicare and, what we could do to maybe rein that in. So it's kind of those two experiences together that got me going.
Are you suggesting paying $56 billion more than the NASA budget for just one drug that doesn't work may not be the right thing with aducanumab?
I'm hinting at that. Yeah.
That's another podcast.
Yeah.
On our last podcast, which had nothing to do with aducanumab, Eric managed to work it in 3 times.
We'll see how many times I get it in this time.
See, we'll keep your score over here.
All right, Matt, I'm going to turn to your paper first, just published in the Journal of American Geriatric Society. So tell me, is this whole polypharmacy thing, and it's specifically for people with dementia, is it common? Is it something that we should actually be worrying about? Is it more common than people without dementia?
Yeah. So I think that our paper, going into the paper, I had kind of a hunch maybe that the answer to those questions was going to be yes. And in writing it up and getting it published, I was blown away by how common it is. It's in fact super common amongst people with dementia that they are affected by polypharmacy, which we kind of narrowly define as taking 5 or more medications. Some people talk about this notion of hyperpolypharmacy or taking 10 or more medications, and whatever definition you use in our study, it was highly prevalent, both in older adults generally, but especially in people with dementia.
How prevalent?
Off the top of my head, I can't remember exactly. I believe in the people with dementia, it was in around 70% were affected by taking 5 or more meds. And I think one thing that was important and unique in the approach was that this description applied to people with dementia living in the community. So a lot of the prior work, very valuable initial studies looking at people with dementia focused a lot on people living in nursing homes, and then in populations that were attending kind of less representative settings like Alzheimer's disease centers. And this is people who are going to their doctor's offices and having regular outpatient visits with their docs. And so it kind of is a real world sample of people, with dementia.
Why do you think that is? Do you think it's just because, people with another comorbidity are more likely to take more meds, or is it something specific about dementia?
Yeah, so I think I think those are all really good questions. We know a couple things. We certainly saw this as well in our paper, but we know that people who carry a diagnosis of dementia tend to have more comorbidities or to have multimorbidity above and beyond the general population. And so that was, one thing we tried to do in this analysis was to adjust for the number of comorbidities, to adjust for age, to adjust for sex. These are well-known phenomena that can affect the number of meds that people are on. And the findings really held up beyond all those factors. So it kind of answers the question of whether the number of meds was being driven by comorbidities, and it seems like there was something above and beyond that. And as to what that is, in your question, I think some of this is really just conjecture, but based on my experience and based on some of the other articles I've read over time, I think you could posit many possibilities, some being the discontinuity of care that people with dementia have as they go through the medical care system. And they may have a number of different doctors who are looking at their medications. They may find that it is harder to communicate either with the doctor or with their caregiver, depending on the stage of dementia, about which meds are working and which ones are not. There may be other factors related to the care of dementia in terms of behavior management that leads to kind of a cascade of prescribing, whether or not that's indicated or has good data, which I would argue it doesn't. It is common practice to treat some of the behaviors that go along with dementia with certain medications. So I think, those are all possible candidates for why. And it was very striking looking at the results in the paper, just how polypharmacy was common, but it was also polypharmacy that was driven by medications from a multitude of categories. It's not just central nervous system medications or dementia medications. It's medications for the heart and medications, anticoagulants like Anna works on, vitamins. It was pretty telling that it went across categories.
And I'm seeing, so I'm just going to look at your table 2 from JAGS. One side of the table is probability of visit with at least one prescribed medication use. And if we just drill down, since you mentioned anticoagulants, so coagulation modifiers, 18% in those with dementia, 13% in those without. Now, is that 18% of people with dementia are on it, or 18% of visits? How should I think about that?
Yeah, it's a kind of a quirk of this data set is that these are estimates about office visits. So the way to interpret that table and that statistic is to say that of a nationally representative sample of office visits in the United States, 18% of them will have someone that's on at least one anticoagulant compared for the people with dementia compared to the non-dementia group that you mentioned. So people walking in the door for their office visits, it's like 1 in 5.
So anticoagulation, very common for individuals with dementia. It is interesting that aducanumab, the exclusion was anticoagulation, yet it's still, FDA makes no mention of that in their labeling. That's 2, Alex says. I got one more aducanumab.
You got 2. We had the Mike Steinman one, so I've been on the podcast 3 times.
Oh, come on. I still got one more.
That was pretty good, too. That was like a nice sly, lied into it.
Well, Mike, we should get your perspective, too, on this. What makes, you're both on this paper and, you're co-PI of the U.S. De-Prescribing Research Network. What makes prescribing so easy and de-prescribing so hard in general and for patients with dementia in particular?
Yeah, it's a great question. I think there's not one single answer, and it's probably the way our entire health system and our culture of medicine has been constructed. But I think probably some of the key factors are that, we as doctors and clinicians, we want to do something to help patients. And oftentimes the way we perceive something as doing something and the patients perceive something as being done or to help them is to give them something, in this case, give them a medication. In the act of taking something away, either sort of denying it in the first place or, God forbid, stopping something they're already taking can be taken as a sign of lack of caring or lack of attention to them. It doesn't, of course, mean that's actually what's being intended, but they can be perceived that way. And so the psychology of it really plays, and I think on both the clinician part and on the patient part, we just want to do these positive things for our patients, and patients want positive things to be done to them. And often the simplest thing that we can reach to our toolbox is a medication. there's of course sort of the unintended consequences of guidelines, and there's clinical inertia, and there's a whole bunch of other factors as well. But I think that really plays into it. Why it's especially prevalent for dementia, I think is not fully understood. One can hypothesize, like Matthew said, about a bunch of factors, patients having more difficulty disclosing difficulties with medication, side effects, difficulties with adherence, which can put further barriers to deprescribing and de-escalation. And again, the sense of, dementia is such a devastating disease. We all want to do something to help these patients because we know we can't do that much for the dementia itself. And so I imagine those things might be playing a role. But either way, it's unlikely to be one single factor. But the positive spin on this paper is we have a lot of room for improvement, which is a challenge, but also says that actually there are things that we as clinicians can do to help our patients, probably by being more judicious in how we think about giving medications for them.
And it is interesting that, for a disease like dementia, where caregiver burden is such a huge issue, that when we were looking at, people with dementia, these visits, I think more than 5 medications or 5 or more medications, 72% with dementia visits had 5 or more, 43% 10 or more. And a simple intervention to relieve caregiver burden may also just be decreasing some of the meds. So you're not fighting over the meds every day. Like you don't have to get them refilled as much. Like why isn't that a bigger issue? And why aren't we stopping some of these medications because of that? Matthew?
Yeah, you're getting close to the things, I guess, that animate me, make me get fiery. But I think part of my interest in polypharmacy is really just the fact that in a case like this, it seems so clear to me that non-pharmacologic support for caregivers and kind of thoughtful approach to which medications are really helping is the intervention more than the kind of totality of medicines that we're giving. Like none of these meds are really, some of them may be guideline concordant for various chronic diseases, but it's clear that kind of in aggregate, the medications are not the solution to this big societal, in my mind, this big societal problem. And you could make another reference to aducanumab at this point. But I think as to why, I don't think my study answers it, but I do think it is really important to think about what is the burden of taking a lot of medications, and in particular, what's the burden in dementia when there may be a dyad or a caregiver who's suffering from burnout. There are some research scales and whatever to scale that kind of amount of burden, but I think clinically, we see that when people come into the office that they're like, I have 3 medication administrations a day, and some of them are inhalers, and some of them are PRN, and then I give half a dose of this. And it also, to me, kind of represents a very medicalized or medicalization of people's life. It can kind of take over the cadence of the day-to-day in a way that, if people have limited time or we're thinking or focusing on quality, that may not be what someone wants kind of a priori. So that, I know that doesn't quite answer your question, but it's kind of related thoughts.
Yeah. I also wonder, Anna, going to you in your paper, we talk about some of these medications may be guideline concordant. So for example, anticoagulants in people with atrial fibrillation. We want to prevent a stroke. A stroke may be devastating to somebody. Keeping these people or starting these people on anticoagulation may prevent a stroke and decrease further disability and frailty. What are your thoughts on that? And what have you learned from your studies?
Yeah, absolutely. I think that's been the dominant perception. And I think this whole paper started with us questioning those guidelines, because if you were to follow guidelines, the vast majority of older adults will qualify for anticoagulation. And as Alex was mentioning, that's just not what happens in real life practice. And it's not clear, I don't think, whether that's quote unquote wrong or not, meaning is that too many or too few? So I think what we really tried to understand is, just as you were saying, stroke is really the most feared complication of atrial fibrillation. But most of the information that we have about how it affects people in the long term is very short time courses, like 30 days. And that's in terms of mortality, but also most importantly, in terms of outcomes that we know older adults and their families care most about, like function. So what we tried to do was using a similar set of data, basically look and see over the long term what happens to those who have stroke and who have atrial fibrillation and suffer a stroke. And how does that compare to a patient who has atrial fibrillation who does not have stroke? Because as we all are aware, atrial fibrillation is a comorbidity that often happens in conjunction with a lot of other comorbidities. It also tends to happen at the same time as other geriatric syndromes. The hallmark one is falls, because that's what we always are worried about and think about in these patients when we're thinking about starting anticoagulation. And so they have a lot of other risks and other reasons that they might lose function over time aside from stroke. So we were really trying to get at those two questions. So hopefully that answers your question. So that was the goal, was we know it's bad in the short term, but what happens in the long term? And also, how bad is it compared to just a patient who has atrial fibrillation who doesn't have a stroke?
I can imagine, just my clinical gestalt, if you got a stroke, you're going to have worse disability. Is that what you found?
We did find that. So, so woo, big surprise. No, not at all. So yes, we did find essentially that there is a big drop in function right after stroke. So underscoring that stroke prevention is super important. But the other interesting things that we found, there's a couple of things. So the first is that, just as I was saying, patients who have atrial fibrillation just alone without stroke, their function declines over time as well, just because it's a marker, most likely it's a marker of frailty and disability in and of itself. But also, interestingly, after stroke, there's that big drop, but it doesn't look like stroke actually accelerates disability. So people continue to decline at the same rate as if they never had a stroke. So that's kind of interesting. But the second part of the analysis is that I think really what I hope we drove home in the paper is that when you take all patients with atrial fibrillation, those who experience stroke, which is about 1 out of 13, it's very devastating. No question about that. But the vast majority of disability in that whole group comes from other things. So stroke in and of itself only accounts for less than 10% of disability. And that includes things like ADL function and IADL function and move to a nursing home. So for all three of those outcomes, stroke is a very minor contributor. And so I think that is what we're trying to get home, that it's very important for the people who experience stroke, but that can't be the end all be all when we're managing these patients. There's a whole host of other things that lead to disability in patients with atrial fibrillation.
And Mike, I'm interested in your thoughts about this as somebody who's a geriatrician and has cared for patients, I'm sure, who have had atrial fibrillation and weighed this decision about whether to anticoagulate or not. Thoughts from you on the implications of this study for your practice?
I think it was really great and important work that Anna did. And I think probably the most important thing of all is it sort of helps to keep our eyes on the prize. I think there's this idea that we often have when we think about medication treatment is like we give the preventive medication, whether it be anticoagulation or a statin or something. And like, if we don't give it, the person's like going to have the event. And if we do give it, they're not going to have the event. And aren't we so great? But of course, we know the number needed to treat is high for many of these drugs, meaning that many people who we give the drug to will have it anyways, and many people who we don't give the drug to will never have the event and would have never had it, even whether or not we would give them the drug. So our difference in these things is often marginal, maybe 5% number of people we reduce an event, maybe 10% if we're lucky. So, something like this really helps keep us focused on the fact that, a lot of these medication treatment choices that we give are not going to make a big difference for our patients. And it doesn't mean that we shouldn't ignore them or we should not ever treat anyone with anticoagulation, far from it. But it means that we need to kind of put it in the broader perspective, both in terms of being realistic about what these drugs can achieve and balancing that against their harms, both whether they're the bleeding events or patient, like Anna was saying, disrupting their quality of life because they're afraid of going out because of the risk of bleeding. And also, it keeps our eyes on the prize about doing other things. Well, what else can we do to prevent functional decline? Even if the person doesn't have a stroke, and are there other things we can do? We know we're not, God, and we can't fix everything, but, I think it reframes us in the big picture is the most important takeaway that I got from this paper.
Well, I feel like, for some of the medications, we're seeing polypharmacy from Matthew's paper, like antipsychotics. It's fairly clear that we should be trying to reduce those. I think some of the cardiovascular stuff, like blood pressure medicines, there still may be benefit. I think when like anticoagulation, I find anticoagulation really hard in my own clinical practice. For example, we had a recent patient with severe dementia, not end stage, but had other comorbidities, admitting him to hospice. And the medicine team said, "Oh my God, why is this person even on anticoagulation? We should absolutely stop it." I said, sometimes we actually have hospice patients that we continue anticoagulation. This person was on for AFib, had a high CHADS-VAS score. I said, it's one of those things that we think about. But as I thought about it for this particular patient, like I wasn't worried about that massive stroke that was going to cause death because, that was something that he was not worried about. I think what was worrying people was what if he had like a small stroke that caused some disability or a series of smaller strokes with his CHADS-VAS, I think gave him a 10 to 12% chance of having a stroke within the year. So Anna, as a hematologist, what should I do for that patient?
Oh man!
And also, given your paper that his function's going to decrease no matter what I do, but maybe there'll be a bigger drop right after he has a stroke. Should I just use the palliative care mantra? It depends on their goals, which is also not incredibly helpful because it also depends on the evidence. It's like, is it going to benefit someone? Is it going to hurt someone?
Yeah, that is that's the Powerball question. And I like Matthew was saying, I think this is one of the things that really gets me riled up because it's a super common question, even for hematology consultants. Like you
and
have
the
a
paper that you did the JAMA editorial on, the JAMA IM editorial, showed that I think a third of nursing home residents with advanced dementia were on anticoagulation.
During the last 6 months of life.
During the last 6 months. So they were, in the last 6 months of life, they were on anticoagulation, just like my patient. And I actually think, because it was like 2 weeks ago, I continued the anticoagulation. Did I do bad? Is that the wrong answer? Am I one of those bad 1/3 of providers?
No. I think the other interesting thing about that paper, and maybe this is sort of like where you were coming from, is that the sickest patients who'd been in the nursing home longest and had the most severe markers of dementia were the most likely to remain on anticoagulants, which is exactly the opposite of what you might anticipate. But so I think that paper really just should serve as the paper we were editorializing on. It's really should serve as a call to action, that there's really no rational framework at all. So I think the issue comes down to, it's sort of similar to Louise Walter's seminal work on how do you decide which patients benefit from cancer screening. And I really think I'm very influenced by her work in that area, in that, we use, just as you're saying, we need to integrate evidence. So we're trying to prevent quantitatively, how much is this preventing thrombosis and stroke, versus quantitatively, how many bleeds are we going to cause? Sure, those should be sort of the pillars, and that's what the CHADS-VAS score and all the bleeding risk scores are trying to get at. But there's all the stuff in the middle that really we need to integrate in a rational way, and that I think has not been done. And that's where I do think that the art of medicine and the role of geriatricians and palliative care doctors, and hopefully hematologists, cardiologists with that same ethos, trained impeccably by Drs. Smith and Steinman, can, and you, obviously, Dr. Woodera, can come into play. And that we should think about how long do we estimate this person has to live such that they might get the benefit, So that's like jumping off of Alex's work on prognosis, because there's so many things that could affect them before even a minor stroke does. We should also think about, just as you did, thinking about, really like if my patient doesn't care about the major stroke, but really still wants to be able to walk around the grounds with a walker, and a minor stroke might prevent that, that should go into that calculation. Or will they be completely scared to do any kind of activity because they get a cut or a bruise from gardening and it just never stops bleeding? Those are the things that we don't always ask about. And definitely researchers do not measure in clinical trials, for example. And that, I think, is where we just need to blow this thing up. Go ahead.
I think in that paper that you editorialized on, people all had very advanced dementia. So very poor functional status. For some of the patients, like the patient I admitted, still was able, not advanced, severe, still able to walk around, still had some potential benefit as far as reduction in disability. I think, the challenge that I'm also thinking about, I'd love your thoughts about this too, Mike, or even Alex, like for colonoscopy, it's clear there's a lag time to benefit. It takes like 10 years to see a benefit because you're trying to find something that's either incredibly small or like precancerous. Is there a lag time to benefit for anticoagulation, or is it like you start something in anticoagulation, you see the potential benefits and harms around the same time? Or do we even know the answer?
I think the answer is, I remember talking to Sachin about this, and who's a senior author on Anna's paper, that benefits accrue almost immediately, as you say, and the curves diverge almost immediately, so that this is a different paradigm from our usual lag time to benefit paradigm. That said, we're talking about risk. The studies talk about risk over a period of time, and it's usually like a year, right? Rather than the short period of time that the patient has left to live. So what do you do with that risk? Do you divide it up into the increment of time that the patient has to live? I completely agree with Anna. We need a new way of thinking about this that incorporates plans, goals, patients' preferences for function, their fears, concerns. It does come back to the geriatric palliative care mantra of goal-focused decision-making. And this has come up not just in atrial fibrillation, but also, as I've talked about with Anna, for venous thromboembolism. Patients who have a DVT or have had a history of PE, they often come to hospice, or we're taking care of them in the setting of palliative care. And we just don't know what to do often with these patients. Should we continue the meds? What benefit are they getting? Is it symptomatic? What would happen if they had a massive PE as a result of the DVT? Is that something that, they would likely end their life? It would likely end their life quickly and hopefully painlessly. Again, the similar sort of scenario, we have to come back to goal-focused care. Anna, any thoughts from you about that?
Yeah, I think I totally agree. And this is my pet issue is I think that we undervalue the patient experience of bleeding. So we're all really scared of the clots, but my clinical experience has told me that patients suffer a lot from bleeding, and we may not know it because it doesn't always come to medical attention. So I think that's another area that I think needs to be further explored as we're making these decisions.
If I could just interject on this topic, two things that you guys are saying that I feel very riled up about right now. One is that the way that we teach and learn about medication prescribing is like a complete void with respect to this kind of lifelong decision making. It's like the medicine is started by maybe a hospital team or a very well-meaning physician at one point in time, and I don't think there's a stewardship of really analyzing every medicine at the level of kind of graceful detail that you guys are going into here. And then as well, with the studies, the way that we kind of decide whether or not to approve medications, how we think about the kind of benefits as they accrue, especially to older people with frailty or older people with cognitive impairment. There's so much richness to what you're talking about that I feel is not yet translated into what we use to say whether or not we want to pay for medicine or whether, so I agree.
So here's a question. What can we do about this? What can we do about these issues? Like, if you could wave a magic wand, we'll take each of you in turn and do one thing differently. What would it be? Would it be education? Would it be the way that we approve drugs? Would it be something about incentives for clinicians? Mike, why don't we start with you first?
You gave me the easy and the hard question at the same time. I wish I had a clear answer, but I think that the thing we really need to do really builds on what what Anna and Matthew were saying, which is about just like taking the time to talk to the patient about their lived experience with the medication and what's important to them, not only in the gross abstract, but like you've been taking, Coumadin for a long time, like, or you're on a DOAC, and like, what's it like for you? Are you worried about these things? Do you bleed? How often? Like, does that bother you or not? Does it restrict your activities? And you get a really different answer depending on who you talk to. But those conversations kind of take time. And, for a busy sort of clinician or physician or nurse practitioner in a clinic, that time is really valuable. So I think a lot of the positive directions we can have in this, sort of taking it out of the physician or nurse practitioner's hands to have those conversations, but engaging pharmacists more in clinic and finding other kind of creative ways to have these conversations to really build an understanding of what the patient is actually experiencing taking the medication and how their goals and values play out into that specific decision.
Yeah, I think that's critical. It doesn't, though, get at the underlying issue that you talked about before, Mike, which is clinicians feel like they need to do something, and the prescribing is the doing something, and the de-prescribing is like going in the opposite direction. So that's got to be a part of it somehow, too.
Absolutely. And so I'm saying education in the broad term because it's really more than education, but it's about motivation and kind of getting people to really sort of buy in and really embrace what you're talking about, as opposed to just sort of lecturing to them, and understanding where clinician barriers are and what their concerns are. Yeah, but this applies as much to clinicians as it does to patients and their caregivers. And it really involves, it's going to be a long-term process of changing the culture of how, and the practices of how we deliver care.
Yeah, we know academic detailing works. Could we do academic de-prescribing detailing? Something like that, right?
Yeah, I don't think so. I mean, I think I do and I do. I don't think so. If you have highly protocolized decisions, like, it's clear that this is a bad medication for this patient, for almost all patients with this situation, then yeah, academic detailing, something like that can work. But the really, how you apply academic detailing to embracing these complex conversations, and creating the structure to allow this to happen and people to act appropriately and get over the deeply entrenched cultural and psychological barriers that we as clinicians have and patients and their caregivers had. Academic detailing can probably start to get us that place, but I suspect that the current model of academic detailing is going to be insufficient to really get us towards that goal. It's going to involve a much sort of deeper level of change.
Mm-hmm. Anna, how about you? You have a magic wand.
Yeah, I mean, I wish I had the wealth of experience to draw on. I'll just pick one thing. I come from hematology, oncology, where clinical trials, that's like all we care about. But I guess I would say I think that there's a moral responsibility to make the clinical trial populations reflect the patients who actually end up getting prescribed medications. So, and I think that's done in certain areas, but not so much in the realms that I work in. And then secondarily, making the population more reflective of the patients who get the drug, and then making sure the outcomes that we measure are the things that matter to patients and their families, as opposed to just medicalizing everything. That's my dream.
Hypothetically, if I were to develop, let's say, an Alzheimer's drug that may barely work, I should probably also, if I'm going to do an indication as the FDA, the indication should look like the people enrolled in the trial. So maybe if it's just mild cognitive and mild dementia, maybe just keep it to those individuals.
Yes, agreed. Yes, this has wide-ranging implications, just as you say.
Matthew,
Eric, your mistake. You do 2 trials, not just one, and then pick the one that works the best.
That's always that is evidence-based medicine. I remember that's what they taught me in med school around evidence-based medicine. Pick the trial that proves your point.
Well, no,
Matthew,
actually shut the trial down early and then bring it back many months later, with new evidence that you bring to light. Sorry, this is we've maybe gone off the rails.
Any other magic wands, Matthew?
I'll, I guess, keep it brief and I guess build on something Mike mentioned. But if I had the magic wand, I would wave it, and it would have a profound cultural ripple effect. It would, because I do think research is important, but I really think at the root of a lot of what we're talking about is culture and kind of biomedical culture, and it would bring patients, physicians, insurers, FDA advocates, everyone into line around kind of exactly what Anna was talking about. So making sure that the things that we do in medicine, so today we're talking about medications, but the medications that we give to people on balance are doing more good than harm, and that they're helping them reach their each individual goal. So it sounds easy, and obviously it's extremely hard, and everyone who's listening to the podcast knows that it's often extremely gray, but I think we can do better.
Well, I want to thank you all. Before we leave, Alex, do you want to end with a little bit more song?
A little bit more. Could drink a case of you. Oh, I am a lonely painter. I live in a box of paints. I'm frightened by the devil, and I'm drawn to those that ain't afraid. I remember the time you told me, you said love is like touching souls. Well, surely you touch mine, 'cause a part of you pours out of me in these lines from time to time. Oh, you're in my blood like holy wine. You taste so bitter and so sweet. Oh, I could drink a case of you, darling, and I'd still be on my feet. I'd still be on my feet.
Anna, Matthew, and Michael, big thank you for joining us for this Jerry Pal podcast.
Thank you so much. That was
fun.
Amazing.
Beautiful, Alex.
Always a big thank you, Archstone Foundation, for your continued support of the Jerry Pal podcast, and to all of our listeners. Thank you for continuing to support the podcast. Good night, everybody.
Good night.